in its breadth, it's visionary, and it's non-traditional. But with each of them comes limitation. It is very weak on evidence on a large part of its recommendation. It is speculative. Likely, at least half the ideas in it will probably be wrong. We can randomize which ones will be right, which ones will be wrong. The unfortunate thing of the document is it doesn't distinguish things for which there is clarity and things that are speculative. I wish the document had done it. Now let me say, it starts with a grand statement, which is hypertension is largely preventable. I do not know the evidence for it, nor does the document provide evidence for it. All the studies of hypertension prevention do show modest impact, not large impacts. And the collective effects of all of those would be that less than 20% of hypertension would be preventable. So today I'd have to say I cannot agree with that statement that it is largely preventable. A significant part of it is preventable. It also goes on to say this document will tell us why detection is low, why treatment is low, and why control is low. But the document doesn't do so. There's very little qualitative information that is reviewed. There are lots of qualitative studies from around the world conducted by a range of researchers where people have been interviewed as to why they do not get their blood pressures checked, why do they not take medications, why is their blood pressure not controlled. And most of the perspective in this document is that of high-income countries. As a researcher who spends most of my research now in low and middle-income countries, it is unfortunate that the qualitative work done in low and middle-income countries is not reflected in the document. For instance, in studies done in Malaysia and Colombia, people say that why would I take medicines for life when I feel perfectly well? What is not included in this document are the barriers to hypertension control. In many parts of the world, it takes a day to go and visit a health professional. And usually, when somebody is in their 50s, especially a woman, they need to have a man accompany them. That is, two people who haven't worked that day. It is true, universal health care will solve a lot of the problems, but it will not solve the distance problem, nor will it solve the problem of individuals needing to lose work to go and see a doctor or even a nurse. There are models of hypertension detection, treatment, and care being experimented in many parts of the world, where the patient doesn't go to the healthcare provider, but the healthcare provider goes to the patient. That, I had hoped, would be reflected in this document. There is this bold statement that prevention will start before conception. Before conception. Not one example of that is given in the document. The document, when you look at low birth weight, Rachel Shaw did a very good meta-analysis. The difference of low birth weight is 1 millimeter difference in blood pressure. That is not a large effect, even on a population level. So we need to be humble in these grand visions. The life course approach is attractive theoretically, but how practical is it? You know, are we going to educate our children on hypertension that they may or may not get 60 years later, or will we educate them on infectious diseases, injuries, safe sex? So you have to choose what you'll educate your children in school. Would you educate them to the risk that they will accrue or be exposed to the next decade, or 50 years later? Which one will have an impact and which one will have an effect? We talk about healthy lifestyles, but healthy lifestyles are not cheap. We just published a paper in Lancet Global Health showing that 5 servings of fruits and vegetables a day in low middle income countries and low income countries is unaffordable by 40% of people in rural communities, and in 20% of the people in urban communities. So again, this is a perspective from the rich countries where only 1% of people, even the poor people, cannot afford fruits and vegetables. The next thing I want to say is we talk about sleep apnea, but I suppose people didn't have a chance to update the article based on the most recent trial that actually shows no benefit for treatment of sleep apnea. Probably it was just a matter of getting this into print while that was not being looked at. Secondary hypertension is fashionable. When I was a student, most of what I learned about hypertension was the extensive investigation into secondary hypertension. Today we know, or at least we think we know, that no more than 5% of hypertension is secondary. Maybe that is wrong. As we have better diagnostics, more hypertension might be secondary. Do we really think that 5% is going to double, triple, quadruple, increase tenfold? Unlikely. Yet, the only simple test for secondary hypertension is electrolytes. All the other things are expensive, and they will bust your bank more than simple screening and treatment of hypertension. So the emphasis on secondary hypertension, while aesthetically and intellectually is appealing, how practical is it? The next thing I want to say is contextualizing. The document doesn't contextualize that the realities in the poor world is very different from the realities in the rich world. I've talked about access to clinics. In one of our studies, which we haven't published, from the Pure study, distance from a person's home to the clinic was the biggest determinant of hypertension control. That's not surprising. And so how do we expect people, when distance even once going to see a physician is a barrier, to go and see them repeatedly? The entire model of hypertension management worldwide has to be turned on its head. And that's what this wants to do, but doesn't do. And what it needs to do is to say, instead of people going to the healthcare provider, it has to be the other way around. And in fact, in many parts of the world, like India, Africa, non-physician health workers go door to door, checking for malaria, giving anti-TB drugs, and various other things, immunizing children. That may be the model for hypertension control in the world. There are many good things in the document, one of which is the use of non-physician health workers. I believe that should be the fundamental and primary way of detecting and managing hypertension rather than physician or even nurse-based. Measuring blood pressure with an automated device, simple automated device, can be done by a high school student or somebody with that kind of level of training. We've just finished creating a module for the WHO under their contract for such a approach. And we are running a study using firefighters in poor communities in Canada to detect hypertension. So I want to end with saying the document is bold, it is visionary. I wish it were much more practical, and I wish it took a perspective that was much more from that term we often use. 80% of hypertension or cardiovascular disease is from low and middle income countries. Unfortunately, that is not the perspective of the document. So I would have to say that this is a great effort, but I would have preferred that it was led and mostly written by people from the middle-income countries who work in those clinics. Remember, in these clinics, the mean time of consultation is 2 minutes. Yes. In that 2 minutes, most of the time, you don't measure blood pressure. So how do we manage blood pressure in those settings? And that would have been something I wish this document had done. So again, congratulations for being bold, visionary, different, non-traditional, and keeping the old fogies up. Thank you.